Breast cancer treatment is, without a doubt, a modern medical triumph. But what happens after the surgery is over? For so many survivors, the end of treatment is actually the beginning of a whole new challenge, chronic and sometimes debilitating pain. So today, we're going to dive into this really common but often overlooked issue. We'll uncover why it happens and, most importantly, explore the real pathways to finding relief.
I mean, you have to wonder, right? Surgery is supposed to fix the problem. So how is it that pain, which should be temporary, can stick around for months or even years and morph into this chronic condition? That's the big puzzle we're going to unpack together.
And the scale of this problem, it's actually staggering. Get this, a major review found that up to 60% of women experience chronic pain after breast cancer surgery. Let's be clear, this isn't some rare side effect. It's a widespread issue that affects a huge number of survivors.
So here's how we're going to break it all down. First, we'll get a handle on what this pain actually is. Then we'll look at the medical and surgical treatments out there. After that, we'll explore a different angle, movement and mind-based therapies. We'll weigh the evidence for all of it. And finally, we'll see why putting it all together is the real key.
All right, let's jump right into Section 1, the pain after surgery. We're talking about a specific condition with a name, post-mastectomy pain syndrome.
So what exactly is post-mastectomy pain syndrome, or PMPS for short? Well, it's not just any old ache you get after an operation. The definition is very specific. It's pain that lasts for at least 3 months, it's pretty severe, and, this is the most important part, it has neuropathic characteristics. In simple terms, that means it's nerve pain. The problem isn't the tissue anymore, it's the pain signals themselves.
And this is not your typical dull ache. People with PMPS often describe it as a burning, shooting, or stabbing feeling. Those are the classic calling cards of nerve pain. It usually shows up in the chest wall, the armpit, or down the inner arm, and it's stubborn. It's there at least half the time. Even a simple movement like lifting your shoulder can make it worse. You can imagine how this constant pain can take a serious toll on a person's quality of life.
Okay, let's move on to Section 2, medical and surgical treatments. How do doctors go about targeting the source of this pain head-on?
Well, when you're dealing with nerve pain like this, the usual painkillers often don't cut it. The goal isn't just to mask the pain, it's to get to the root of the problem, which is calming down those overactive nerves that are basically misfiring and sending faulty pain signals to the brain. The official guidelines usually point to 3 main types of medication to start with. First up are neuromodulators like gabapentin. Think of them as a dimmer switch for your nerves, just turning down the volume on those pain signals. Then, you have certain kinds of antidepressants that work on your brain chemistry to change how you perceive pain. And a third group, called SNRIs, do a similar thing. They're all designed to work on the central nervous system to quiet things down.
Now, if medications aren't doing the trick, there are more direct interventions. On one hand, you have paravertebral blocks. These are injections right near the spine that give you really fast but also pretty short-term relief. On the other hand, there's a technique called pulsed radiofrequency, which uses an energy wave to kind of reset the nerve. It takes longer to kick in, but the relief can last a lot longer, sometimes up to 6 months. It's a classic trade-off, really. Do you want relief now or relief for longer?
And in some select cases, believe it or not, the answer is actually more surgery. This is usually reserved for situations where there's a really clear physical reason for the pain, like a specific nerve that's been damaged or trapped in scar tissue.
2 surgical approaches in particular look really promising. The first is called fat grafting. Multiple studies found that it significantly cut down on pain. The thinking is that the injected fat helps release tight scar tissue, giving those compressed nerves some breathing room. The second is for a very specific problem called a neuroma, which is like a painful, tangled ball of nerve endings. For those patients, surgically removing that neuroma brought relief to over 80% of them. That's huge. So these are definitely powerful options for the right person.
All right, let's switch gears and look at a totally different way of thinking about this. Section 3, movement and mind therapies. This is all about physical rehabilitation and, just as importantly, using the power of the brain to help manage the pain.
And let me tell you, the evidence for this approach is really solid. A huge meta-analysis from 2022, that's where they combined the results from lots of studies, found a, quote, significant improvement in pain severity for people who got physical therapies. So this isn't just a nice idea, it's backed by top-tier scientific evidence.
So, which therapies made the biggest difference? Well, that same big study highlighted 3 heavy hitters: structured exercise programs, something called myofascial release, which is a type of hands-on therapy for the body's connective tissue, and acupuncture. As you can see, all 3 of them showed a clear positive impact on bringing pain levels down.
Now, beyond just physical movement, there's a ton of growing interest in therapies that really focus on that mind-body connection. The research here is a bit newer, but what we're starting to see is really exciting.
So let's compare 2 really popular mind-body practices. A solid study on mindfulness-based therapy found that it led to a statistically significant and lasting drop in pain. That's a big deal. For yoga, a much smaller study also saw a positive trend, but the results didn't hit that statistically significant mark. Why? Most likely because the group was just too small. It's a perfect example of why the size of a study is so critical for proving if a treatment really works.
Okay, Section 4, what the evidence says. We've thrown a lot of different options at you, so let's take a step back and try to make sense of it all by looking at the strength of the science behind each one.
The big takeaway here is that not all treatments have the same level of proof behind them. It's helpful to think of it like a spectrum of certainty. On one end, you have treatments with a high level of certainty, backed by the best kinds of studies. Things like exercise, myofascial release, fat grafting, and certain meds fall in this bucket. On the other end, you have promising therapies like mindfulness and yoga that just need more research to really nail down how effective they are.
And all of this leads us to our final, and honestly, our most important section, the multimodal approach. Because with all these different tools in the toolbox, what's the absolute best way forward?
If there's one thing you take away from all this research, let it be this: there is no single magic bullet. The most effective strategy is a personalized care plan built by a team. It all has to start with getting the diagnosis right. From there, you layer on the different treatments that make sense for that person: medical care to handle the nerve signals, physical rehab to get function back, and, crucially, psychological support to address that powerful mind-body connection.
And hey, don't just take my word for it. The experts who study this stuff are all saying the same thing. A major review from 2021 flat out says that the evidence supports a multimodal, multidisciplinary approach. In other words, it's about building a dedicated team and creating a custom toolkit for every single patient. So, that leaves us with a final, really powerful question. We know what works best. The science clearly points to a personalized, team-based approach for managing this kind of complex pain. The challenge we face now isn't really a scientific one, it's a systems one. If the future of pain care really is personal, how do we build a healthcare system that can make sure every single patient actually gets the team they need?